Hello there, this is Dr. Mintz. This is a case of a patient with shortness of breath, and it prompted a pulmonary embolism CT to be done. Truth is, it doesn't require a whole lot of prompting to get pulmonary embolism CT done. It is the feeling of some radiologists that it is vastly overused, but that's another subject. Just to kind of give you a heads up about that. Maybe you've heard it, or maybe you have not. So here are the coronal images. I'll just give you a chance to look at that, kind of get your bearings, maybe develop an idea or two about what might be going on. Now remember, it's a pulmonary embolism CT. So we're looking for pulmonary emboli, of course. So here are the axial images. But as I mentioned, we do these very commonly now for people who have shortness of breath or chest pain or both. This is a very good exam for finding abnormalities, but it's a fair amount of radiation, and it's not something we should take lightly. So take a look at this. And so if I were to point at this structure right here on a test, would you know what it is? If I were to point at this structure, would you know what it is? If I were to point at this structure, would you know what it is? Well, let's look at this one first. We'll kind of skirt up a little bit and down. So where's it coming from? It's coming from the right ventricle, right? The right ventricle is more anterior, the left ventricle more posterior, and the left ventricle has a thicker myocardium, although not all that thick in this particular case. So it comes from the right ventricle. It's positioned anteriorly in the mediastinum. What is it? It's the main pulmonary artery. And the main pulmonary artery arches upward and back to divide inferior to the aortic arch, or thereabouts. So this is the ascending aorta, descending thoracic aorta, and it branches somewhere under there. Okay. This, of course, is the superior vena cava. So on these three images you have main pulmonary artery, ascending aorta, SVC. Okay. What is this structure right here? Let's see. We'll back up a little bit, go down. Where is it coming from? It's coming from the left ventricle. So that left ventricle is emptying out through this channel into this vessel, which of course is the ascending aorta. And here you see its relationship to the main pulmonary artery and the SVC. Look at the size of this main pulmonary artery. Look at the size of it, the diameter, the right and left main pulmonary artery, compared to the aorta. The main pulmonary artery, of course, is much bigger than the aorta, and this right main pulmonary artery is quite a bit bigger than the aorta as well. What does that indicate? It indicates pulmonary arterial hypertension. And it means that because of destruction of capillary beds in the lungs as a result of typically chronic obstructive pulmonary disease, COPD, which includes emphysema and chronic bronchitis, as well as other processes that can destroy lung tissue. With the destruction of those capillary beds, you have an increase in resistance to flow from the pulmonary arteries to the pulmonary veins. In other words, pushing blood through the lungs and getting it back into the left atrium encounters a great deal more resistance. And so this enlargement reflects that increase in resistance, and that increase in resistance also produces pulmonary arterial hypertension, so they all are tied together. Okay, so we don't see pulmonary emboli. This is an excellent example of the kind of images you can get with the timing that is afforded on our new fast scanners. So we can inject the patients. Let's see which extremity was injected here. Not hard to figure that out. The left. So it entered the left brachial vein or somewhere around there, then comes into the left subclavian vein, and then this is the left innominate vein, and the left innominate vein then crosses to join the superior vena cava. And here you can actually see the mixing of this contrast opacified blood in the left brachiocephalic vein with the unopacified blood in the right brachiocephalic vein above that level. So as we go down, we'll see this contrast opacified blood mixing with this, and that's basically what you get there. So sometimes it layers out and separates one from the other. So here you can see there's a flowing portion of blood in the superior vena cava, which is predominantly from the right brachiocephalic vein. So this is not a thrombus, not a clot, not a tumor. It's just that the mixing has not occurred to a very great extent. You can see this diminishing as you go down as more and more mixing is occurring. So if we go from the SVC and we follow that inferiorly, where is the SVC going to empty out its content? Well, is it oxygenated or deoxygenated blood? It's deoxygenated blood. It's coming back from systemic circulation, so it needs to get reoxygenated, so it needs to go into the right atrium, which is here, so it can go in the right ventricle, and then back through the lungs. So again, look at this. Main pulmonary artery, aorta, SVC. The SVC courses inferiorly to empty its deoxygenated blood into the right atrium, which in turn empties its content into the right ventricle. Right atrium, right ventricle, and sometimes if you window this, you might see little hints of a valve there. This may be a valve leaflet here that's open. This is a chorda tendineae, or maybe small papillary muscle. There's part of the valve complex right there. Anyway, this is right atrium, right ventricle. Now, keep in mind, where is the right ventricle going to give rise to the main pulmonary artery? Remember that it's very anterior, so it comes, this is the sternum, comes up out of the right ventricle and arches back. And then it branches right under the aortic arch. Let's see if that holds true here. Here we are in the right ventricle, the course upward. Here is the main pulmonary artery exiting superiorly, just posterior to the sternum. So that's the main pulmonary artery, and at some point you will see it branch to the right and to the left, inferior to the aortic arch. I think this looks farther off to the side than most pulmonary arteries when they branch inferior to the aortic arch, because it's just gotten so fat, so big from pulmonary arterial hypertension that it can't fit under there anymore. Even the one right main pulmonary artery can't fit very well. Okay, so that gives you an idea of those anatomic areas that are conducting this opacified blood. So what do you suppose these vessels out here are? Well, if you connect them, you'll see that they connect to the main pulmonary artery, and look how tortuous they look. See these right here, this one's all curled. That's something you see usually in systemic arteries when there's hypertension. So if someone has a long history of hypertension, you look at the carotid arteries, for example, they'll be curly, and sometimes the vertebral arteries will be too, and they can look even loopy sometimes if there's a long history of that. But it's very uncommon to see this severity of pulmonary arterial hypertension to the extent that you actually are getting tortuosity, curliness, if you will, of the proximal pulmonary arterial branches. So let's go to another plane. Coronal plane. If I show you that image, I not only want you to know what this structure here is, but why? It's coming from the right ventricle. It's pretty far anterior. It's just posterior to the sternum. So that's going to be the main pulmonary artery. And you can follow that upward. Note again that it is markedly larger than the aorta. So that's a strong indicator of pulmonary arterial hypertension. And here you see the right main pulmonary artery, the left main pulmonary artery. Wait a minute. Why is the left main pulmonary artery going up so high? Well, one reason is it usually does. And remember what I showed you before, that if this is the right and left main stem bronchus, the right main pulmonary artery is anterior to the right main stem bronchus. The left main pulmonary artery goes up and over the left main stem bronchus. So what you're seeing here is that left main pulmonary artery coursing up and over the left main stem bronchus, which is this structure right here. Okay, so that suddenly also demonstrates the kind of problem this patient has. So look at this. These lungs don't look good. They don't look right. What's wrong with them? And this is where having some familiarity with radiologic nomenclature and the way that we communicate with reports is important, because you can look at it and see this is abnormal here, and this is abnormal, and maybe this is abnormal here, and gee, these areas look too dark. This looks too dark. But you want to be able to describe it. Okay? So this is how I would describe it. And probably better, a little more readily identifiable, some of these findings on axial images. Well, there are hyperlucent areas in the lungs bilaterally. That is typical of pulmonary emphysema. You will see that there are areas that lack any internal architecture, or lack most of the internal architecture. There may be a little fine septum here, and if we look over here, also very lucent. So these hyperlucent areas of the lung are typical of pulmonary emphysema. There's destruction of lung tissue, and it's that which causes not only the difficulty with the patient's breathing, but also the increase in pulmonary arterial blood pressure. Okay, so let's make that a little bit bigger. And something else is abnormal here. So there are hyperlucent areas in the lungs bilaterally, which we could call bullous changes, or just bypass that. This is a bulla, an emphysematous bulla, B-U-L-L-A. The plural is B-U-L-L-A-E, but people don't usually say bulli, but it's proper to say it. And you have some ground glass opacities here, so even the lung that is not destroyed, is not bullous, has some abnormalities producing this, what we call ground glass opacity. In case you don't know what ground glass actually means, it's something that they would put, for example, on the glass of a shower enclosure so that it allows light through, but it's actually ground, like with some type of metal or rock that gives it such a very uniform but scratched up texture that you can't see through it in detail, but it allows some light through. So that's what is meant by ground glass. So there are ground glass opacities. What else? So we have emphysematous bulli, ground glass opacities, and look up here. This is not right. We have these areas of soft tissue attenuation. There are areas of frank soft tissue that are the same attenuation as muscle. And look at this. This is not a vessel. This is not a vessel, so there's pleural thickening. And these are areas of fibrosis, basically scarring. Bilateral apical fibrosis. Bilateral apical fibrosis. Look at it in the coronal plane here now. And I'll go back to the soft tissue. See, you have apical fibrosis here. Some of it is actually going through parts of the lung. So this is all fibrotic tissue. Notice something else very interesting about this COPD patient. COPD being chronic obstructive pulmonary disease, and that encapsulates chronic bronchitis, asthma, and pulmonary emphysema. Look at the hilar. Now, if we were to look at the chest radiograph on this person, let me make it a little smaller there. You see the hilar? The hilar are too high. They're pulled up. That's called hilar retraction. So look at it here on this kind of chest radiograph image. You can see the apical pleural thickening, which is most pronounced on the right. You see a band of fibrosis here. You see areas of linear fibrosis coming from this apical area toward the left hilum. And what's happening is the hilar are actually being tethered by those fibrotic changes and pulled upward. So let's look at the CT of that and put that on a nice intermediate window. Maybe that'll work. Look how high the hilar are. The left is way up there. It's at the level of the aortic arch. And if we put it on more of a lung window, maybe darken that up a little bit, you can see some of these lines, these fibrotic areas that are actually connected to the hilar and are pulling the hilar up. So hilar retraction, because of biapical or bilateral apical, we shorten and say biapical fibrosis, is something that we see in COPD patients, particularly emphysematous patients, and actually it's particularly common in people who have inhalational diseases where they've been exposed to various substances, and the classic diagnosis that causes that is coal miner's pneumoconiosis. So people who are coal miners will develop something like this, and also silica, another material that is mined that can produce silicosis and hilar retraction secondary to bilateral apical fibrosis. So pick up on the terminology that I use so that you can converse with it, and instead of looking at something like this and seeing what's wrong and seeing where it's abnormal, but you acquire a vocabulary for lungs and hyla. So this, you could say the hyla are up too high, but the proper term would be hilar retraction. So there's hilar retraction here, secondary to bilateral apical fibrosis. And this suggests chronic inhalational exposure to silica or coal mining, or may just be due to a more fibrotic version of pulmonary emphysema. But you see there's some pleural thickening in other portions of the chest as well. Now, we don't use sagittal images very often in the chest. They're probably the third choice. We go through the axials typically, and certainly for a pulmonary embolism protocol, we give close attention to the coronals. We would also look at the sagittals just because it's another chance to look at the pulmonary arteries, and not just the main pulmonary arteries, but here we're referring to the branches. So here is pulmonary artery, and this is actually the left lower pulmonary artery. It's just pulled up very high. So this is another opportunity to look for filling defects in the pulmonary arteries, and therefore increase our sensitivity to pulmonary embolism. Most cases of pulmonary embolism are pretty obvious, big chunks of blood clot on both sides, but not always. Sometimes it's just a little tiny bit. Okay, so if you looked at this is a little obscure, but it's a challenge to your understanding of anatomy, and if you can rationalize things out and figure out what you're looking at on sagittals, that's probably a very good thing. So this is a vessel of some sort that's going down to a chamber of the heart. What chamber of the heart do you think that would be? And what vessel is this? Well, you can tell it has thin walls, so it's not an artery, it's a vein, and this is the superior vena cava. And here is the mixing that we were talking about. We have unopacified blood from the right brachiocephalic vein kind of congealing and staying together partially and not mixing very well, at least initially, with the blood from the left brachiocephalic vein. So that courses into this chamber. You know it's going to be an atrium. Is it left or right? Let's look. Follow it this way. Follow it this way. Well, here's the right ventricle because you can see it going out the main pulmonary artery. So if we go over to the right from there, this should be the right. Well, this is right ventricle here. And so if we go over this way, you can see that there's a communication here from this chamber to the right ventricle. In fact, you can even get a sense of the movement going there. So blood comes down the superior vena cava, so blood courses down the superior vena cava into the right atrium, which then empties into the right ventricle. Here's the left ventricle. We follow that back, and Kind of hard to see the left atrium here, but should be right here. Well, that's the aorta. So this is a reminder of the anatomy in axial plane, showing you that the right atrium in this patient is quite large. Why? Well, the patient has pulmonary arterial hypertension, and the heart is struggling to empty out the contents of the right ventricle through this highly resistive pulmonary arterial bed. And so that back pressure does go back to an extent to the right atrium, which is what we're seeing here. That's dilated. The left atrium then is going to be small. And here's the left atrium here. How do I know it's a left atrium? Looking at this, you know this is the main pulmonary artery, ascending aorta, superior vena cava. Does the superior vena cava go into the left atrium? No, because the left side of the heart needs oxygenated blood. So the blood that's going to go into the left atrium and then go out the left ventricle into the aorta has got to be oxygenated blood, fresh from the lungs. So what you're seeing here are pulmonary veins. And very often you have two prominent ones on each side, but not always. So you have one here, one there, and they go into this left atrium, right here. And on the right, you also have a vessel here, that goes into the left atrium with its newly oxygenated blood to go from the left atrium into the left ventricle and then out the aorta. Okay. I hope that's given you some orientation to the anatomy, a different version of it. Things are distorted a little bit because of the patient's condition, but you're now getting a little more experience with the anatomy of the chest and seeing an important type of process that we see, and that is COPD. And let me just point out on the coronal image another finding of COPD, and that is that the diaphragms tend to get flattened. The lungs become somewhat hyperinflated, and the diaphragms start losing their nice curvature, their nice arch. So flattening of the hemidiaphragms is a characteristic finding of COPD.